Welcome everyone. In this high-yield explainer, we're going to cut straight to the chase on breast tumors, focusing on the critical, board-relevant points you absolutely need to know.
Okay, let's just dive right in. We'll start with the essential clinical approach. Then we'll systematically break down the key benign and malignant tumors, and we'll wrap it all up with the highest yield signs and risk factors you need to have locked in. So let's start by framing the fundamental clinical problem. The very reason all these pathologies come to our attention in the first place.
This is it. This is the core question we face every single time. And the first clue to answering it often starts with a really simple question of anatomy. Where exactly is the lump located?
Now, what's so fascinating about this slide is the distribution it shows. A staggering 45% of cancers pop up in the upper outer quadrant. So why there? Because that's where most of the glandular tissue, including the axillary tail of Spence, is located. It's a simple but absolutely vital piece of anatomical trivia. Let's move on to our first category and see how the common benign tumors typically present. And we're going to start with the most frequent one of all. We'll kick things off with the fibroadenoma. It's a really well-circumscribed lesion, and it's actually the most common benign tumor, especially in women under 35. What's crucial to know is that it has two distinct pathological personalities, which we're going to look at next. So the most crucial point on a clinical exam is its mobility. It feels like a little marble that just slips away from your fingers, which is why it has that nickname, mouse of the breast. And histologically, the consistency you feel relates directly to the pattern. The hard paracanalicular type has really dense tissue surrounding open ducts, while the softer intracanalicular type has looser tissue that's compressing the ducts into little slits. Okay, next up is the intraductal papilloma. Now, even though it's benign, it's famous for causing a very specific and often pretty alarming clinical sign that gives us a major clue that it's there. And this just brilliantly illustrates the link between the pathology and the presentation. Just look at the histology. You've got these finger-like projections with a core of vascular connective tissue. And it's this fragile vascular core that bleeds so easily, leading directly to that classic presentation of bloody nipple discharge. Now, for a really fascinating tumor. It starts off looking like a benign fibroadenoma, but it has the potential to grow to an absolutely massive size and even behave malignantly. Just look at the sheer size of this gross specimen. They're called giant fibroadenomas for a reason. These tumors can grow incredibly fast, often taking over the entire breast with their characteristic bossylated, which just means knobby or lobulated surface. The key takeaway here is that even though it looks a lot like a fibroadenoma, it's the presence of a sarcomatous-like stroma that signals its potential for malignant behavior. And this is critical. When it does become malignant, it spreads through the bloodstream like a sarcoma, not through the lymphatics like a typical breast carcinoma. This is a crucial distinction. Let's move on to the earliest stage of malignancy, where the cancer cells are there, but they're contained. They haven't yet learned how to invade. The single defining feature of any carcinoma in situ is that the basement membrane is perfectly intact. It's like a wall, and it's containing all the malignant cells. This includes both ductal carcinoma in situ, or DCIS, and lobular carcinoma in situ, LCIS. They're both contained, but you'll see their appearance and their behavior are quite different. This micrograph demonstrates DCIS just beautifully. You can clearly see the breast duct is packed, completely filled with these pleomorphic, which just means variously shaped malignant cells. But they're still confined within that ductal basement membrane. Now contrast this with LCIS, which you can't see here. In LCIS, the cells actually lose their adhesion molecule, E-cadherin, so they don't really form structures. They're just kind of discohesive and loosely fill up the lobules without expanding them. So what happens when those contained cells finally breach the basement membrane? Well, that's when we enter the world of invasive carcinoma, and the prognosis changes dramatically. We'll start with the undisputed heavyweight champion of invasive breast cancer, invasive ductal carcinoma. This single type accounts for about 70% of all invasive cases. Now, look closely at this histology. You see these irregular clusters of malignant cells, right? But what's surrounding them is just as important, that extensive, dense, pink fibrous stroma. This is called a desmoplastic reaction, and it's what gives the tumor its classic hard, gritty texture on gross examination and when you feel it. So this table compares our two main invasive types. For invasive ductal carcinoma, that dense fibrosis we just saw is the key. It infiltrates and pulls on Cooper's ligaments, which causes skin dimpling, and it can retract the ducts, causing the nipple to invert.
Now compare that to invasive lobular carcinoma. Histologically, it's totally different. The cells lack E-cadherin, so they don't form clusters. Instead, they invade in these single-file strands, what we call an Indian file pattern. Clinically, this means it often doesn't form a hard, distinct lump, making it much harder to detect on both a physical exam and on mammograms.
And we absolutely have to mention two critical special types. First, inflammatory breast cancer. It's incredibly aggressive and it mimics an infection or an abscess, which can tragically delay diagnosis. It has a very poor prognosis. Second is Paget's disease of the breast, which doesn't present as a lump but as an eczema-like rash on the nipple. You should always consider an underlying malignancy with a non-healing nipple rash.
Okay, to wrap this all up, let's distill everything down to the most important clinical takeaways, the red flags and the risk factors that you absolutely must have on your radar.
So, the most crucial point is this. Any sign of fixation or tethering is a major red flag. Think about it in 4 zones. The mass itself, is it hard and fixed? The overlying skin, is there dimpling or that poterange texture? The nipple, is it retracting or does it have an unusual discharge? And finally, the axilla. Can you feel hard, palpable nodes? A yes to any of these should really raise your suspicion for malignancy.
And finally, knowing the risk factors is so key for screening and prevention. You can really group them in your mind. You've got the genetic factors, like BRCA mutations. There's personal and family history. There's prolonged hormonal exposure. Then there are demographics like age and geography. And finally, other factors like obesity and radiation exposure. Understanding this profile really helps us identify our highest risk patients.
And this leaves us with a kind of forward-looking question. Right now, we draw these really clear lines between benign and malignant. But as our molecular understanding grows, will that distinct line begin to blur into more of a continuous spectrum of risk? That's really something your generation of clinicians is going to help define.